Sounds like we have established a quorum. And I'll call the meeting to order for April 24, 11 a.m. for the Fisher's Health Department. Nailed it. Welcome visitors. Okay. Motion to approve the prior minutes, is that right?
I'll make a motion.
Second. All right, all in favor? Aye. Against? All right, we approve. Now what do we do? We go into the minutes?
Now you're on to the regular item. Regular items, yep. We already did the minutes.
We're already at number 5.
You're already into the five.
Good job.
Doing it. Doing it.
All right, I guess we need a vice chair. Is there, should we wait until everyone else is present or we have
I'll wait a
someone?
few more minutes.
Yeah, we can table that one for now.
Okay, let's table that. All right, so last time we had talked, there was a budget stuff, but because the state was. Basically, we were waiting for the state's budget before we came up with some
I have
ideas.
a presentation for you on that, but before we get to that, I don't know, hopefully you all received the 2024 annual report draft that we sent out, so I don't know if we could
Does that require formal
consider
approval?
approving that.
I'll make a motion to approve the 2024 annual report. Second.
Okay, all in favor, say aye.
Aye.
Yes? Looks like that budget passed, right?
Annual report.
Annual
Annual
report.
report. Annual report, okay. All right, on to C. Yeah. All right, for the Fisher's Health Department updates and 2025 priorities.
A lot to chat about.
Wow, so who takes this over?
So I'm gonna start and then I'm gonna hand it off to the team. Laura, I also want to introduce Jen Engelman. She's our new Assistant Director of Operations. And then Josh as well, our Assistant Director of Strategy. So, but just before we do that, I wanted to say happy birthday to us. We are 5 years old today. Hard to believe. Happy, Scott probably never knew what he was getting into when he gave himself a happy birthday present. 5 years ago, but as part of the leading up to this, we started like just tracking and putting together some of the numbers of services that we've done and keeping in mind most of these services have only been in effect for 2 years, you know, maybe 1 year. And we've had these on social media all week, but I thought I'd share them with you guys. We've had over 23,000 sessions with over 20,000 users to our Credible Mind platform that we use for mental health. And that's in only about 2 years. We have had almost 10,000 non-COVID related clinical visits, which, you know, is in addition to the over 120,000 COVID vaccines and over 120,000 COVID tests that we did during COVID. But additionally, 10,000 non-COVID related clinical visits. More than 700 unique educational sessions have been delivered with hitting over 35,000 people in the community, whether it be in the schools or out in the community. More than 3,000 food inspections that we've conducted, more than 1,300 pool and open water inspections. Our social work program has really been only up and running for a little bit over a year, and we've had over 120 home visits, almost 1,300 people served, and almost 2,600 unique encounters by that program alone. We've had almost 19,000 vital records have been issued. So birth and death certificates. Yeah. Yeah. We've investigated over 1,200 reportable conditions. So all those lead, childhood lead, animal bites, tuberculosis, latent tuberculosis, Shigella, everything you can get, pertussis, everything you can think of, all those reportable conditions. And then related to the fall prevention program, we used a recent study by IU Fairbanks. It was just an initial study from the School of Public Health was contracted to see effectiveness of HFI funds on specific programs. And so they shared their formula that they used to calculate return on investment for a couple of different programs. And the program that we can match is the fall prevention program. So just on the services that we've provided in just over a year in fall prevention, we're calculating over just under $1 million in savings, either directly or indirectly due to decrease emergency care, et cetera. So that's pretty cool. So just happy birthday to us. We've got things to share and you know, hopefully you'll all celebrate by sharing the good news of all the work that we do. Other updates that we have that I just wanted to make sure the board was aware of are that vital records are being issued out of our office for all Hoosiers for any event that happened after 1907. That's the date apparently where we can back scan things to, or that's in the state system. From early polling from other health departments seems to indicate that about 50% of health departments are doing this and 50% are not, at least from the ones that answered a informal survey, not conducted by us. But we are seeing that people are taking advantage of that, and we're able to issue records now for anybody that was born in or died in the state of Indiana after 1907. Other news, a couple weeks ago, the governor signed into law the updates to the food code. So this food code does some things to update and put in line the Indiana code in line with FDA standards. So that logistically, that means we have a few things to do. So we're already kind of using the tools that have been in place with that, but to make our system updated so that we can, you know, make the inspection reports concurrent with that. We're still updating those systems, but we are inspecting according to those principles. The state has, I think, asked that that fines and I don't know, citations don't come into effect until later, but we're working to get all that lined up. And there shouldn't be any surprises. We've been talking about it with all of our operators for quite some time, but it has been signed into law, so we are moving forward with that. And then finally, on certified pool operator classes, I think I mentioned last time our pool inspector has received certification to be an instructor for certified pool operators, which is a requirement under our ordinance that people have in order to operate a public or semi-public school pool. So he's now able to offer those classes, and we had passed through council on Monday night an update to our fee schedule so that we can formally offer those at the fee that we're required to charge by the certifying body. So just updates on things that I had mentioned before that are now active.
This is to go to any other slides.
Yeah, I think you can move it along. So this is just a review of some of the priorities that we're working on this year. Obviously, Health First Indiana has its own set of stipulations and priorities that we're working through and making sure that we're in accordance with. We're working towards accreditation readiness, and we'll give an update on the community health assessment data today. We'll working towards expansion of those clinical services. We'll give an update on that today. Obviously working on continued integration and collaboration with our public safety partners, with our social work team, continuing to expand community-based educational offerings. And we have a few new things on the books that we'll be offering this year related to that. School health, continuing to partner with our school partners, and then putting those things into effect from IDOH that we talked about just now, as well as getting ready for another move over to the community center in October-ish. And I'm gonna hand it over to Laura Gropp to talk about the HFI.
Okay. So it's been a busy month or so with all the changes that are happening at the state and federal level. So we've been working busy behind the scenes to take a look at our revenue projections and expense for 2026 and years beyond. Based on property tax projections for 2026, we also have a loss of federal grant funding sources, and then some funding cuts that are proposed at the state legislature right now for HFI funding. So if you look at 2025, you'll see our revenues in the blue column of all sources. That's grants, operating, which is funded by property taxes. And then our HFI, we received a little over 3.7 million this year with our expenses at 3.6. For 2026, our revenue will be decreased to 2.4 million, and we will still have expenses around 3.7. So we are projecting a deficit of about 1.3. Working through ways we can decrease that deficit. Obviously, moving to the community center, we won't have the cost of rent and utilities and common area maintenance. But also working with the mayor and administration and finding ways that we can increase our revenue and trying to sustain ourselves moving forward. And you see that kind of projects through the following years.
I think if I could add maybe a bit of commentary. So it's not proposed legislation, this is approved. The budget was approved yesterday or will likely be signed by the governor here shortly. And it does constitute a 73% reduction roughly in the amount of new money that public health departments were getting after the last 2-year budget. So if you recall, kind of historic move forward in public health in terms of funding to local governments, and then now we're walking back significantly to the tune of 3/4 of it basically. We just found that out yesterday. We were anticipating a reduction, and so we've already been contemplating these particular scenarios. Did we anticipate a 73% reduction or 70% reduction? Certainly not. But I wouldn't raise the alarm bell yet. I mean, we're a group that thinks our way through these issues, and I feel confident that we'll come up with a good plan. Just this morning, having looked through Laura's numbers, we identified a fairly significant step forward in what the revenue actually will look like. And so it's just too early to get into the sky is falling or hear all the things that we need to do. I think our commitment to this board is that we will be back before you at the next meeting with a real concrete plan on how to address this moving forward, you know, and I feel by that time we'll have a lot of clarity and some creative solutions to bridge a gap. There's also a component of this, you lose the state dollars, but the property tax reforms for us are really kind of a 2-year window that you feel significant loss, and then you start to build your way back up. So that all needs to be brought together to really contemplate, and a lot of moving pieces here, but I think we'll have more information next couple months. Any questions on all that?
Yeah, I'm curious. So obviously the funding was augmented. Was there any statutory augmentations to the required mandated services provided by health departments, or did those all?
That's a really great question, and one that I asked some of the legislators last night. And there's some ambiguity on that because I don't know how much of that was done at an administrative level. So I don't know if Dr. Weaver now is going to come out with a different set of requirements or whether that was legislated. And so I don't know yet what the answer is to that question, but it's a great, what are the expectations now with 25% of the funding that they originally provided? I don't know the answer to that.
I don't know the answer to that either. We haven't had any communication from the state since the budget was released last night. I haven't had a chance to look at whatever the final version is, the Senate version. I think I sent maybe to you guys. The Senate version had some proposed legislated changes, but that was still assuming that it was a I can't remember, 33% cut to Health First Indiana, not a 73% cut. So the deeper cut would seem to suggest that there are less expectations.
Okay.
But we'll factor that in. And just another point on some of this, Laura and I have, and Josh and Jen have been working on this ever since the governor's budget came out with an expectation that we were going to have cuts. And then we've continued to adjust as like the federal situation and grants have changed. and those kinds of things. We're also concurrently working on really that clinical services plan from a kind of a business plan standpoint, like what can we realistically expect to use to offset. We've got things that, again, this is based on, I think, assumptions that are in line with our this year's budget. So there are things like the community center move that should allow us less of a kind of gap, less of that under, because those are things that we won't have to pay for going forward.
Yeah.
So,
Also, some of the federal funds were for kind of like line item programs, or is there like an expectation that when the funding stops, the program may stop, or is that still just in determination?
so, we're obviously like trying to maintain all the programming, right?
Of course, yes, yes.
Didn't have any like very specific federal funded programs that were like this is for disease investigations and you can only use it for disease investigations. Now you don't investigate diseases. That we don't have anything like that. One of the biggest impacts to us was actually the cutting of grant funds that we didn't even know were on COVID dollars. So when the federal government cut the COVID dollars, like these were general vaccine funds that were meant to support like childhood vaccines. But, when the state kind of packages their funding together, they do the same thing we do, which is they mash together funding streams and then they give it out. And so the person that gets it doesn't always know what those funding streams are. So, just working through all those issues, we're capturing every possible thing that we can recapture, being really kind of eyes wide open and trying to troubleshoot all of these idiosyncrasies. And I think, we've done relatively well, and I feel confident that we're going to be better positioned than most, but we're going to be proactively planning the whole time, and we're fine for this year. So, so the funding side, the state budget cycle and the funding cycle is usually July to June on a 2-year cycle, but when they implemented Help First Indiana, they offset it by 6 months. So the Help First Indiana funds are calendar year, which makes it easier for us to plan since that's our budget cycle as well.
So I think if you guys would allow us 30 days, 60 days to really scrub the revenue assumptions, really get a handle on where our expenditures are, where these programs are at, and then I think we come back with a roadmap. And then if there are decision points for the board to say, what of these two priorities are, hopefully we're not in that situation, but if we had to come to you and say, which of these priorities do you think we need to maintain? We would pose those questions to you guys and we kind of pick one or the other kind of scenario. So more to come on that.
Anything else with the budget?
I have a couple other slides just to kind of talk about revenue, where we're at, and also look at where we're at in revenue at the end of 2024 in each of our program areas. So you'll see we have like our environmental bucket, our vital records, clinic revenue, other revenue, which includes like our classes, and then the total for the year. So it may be hard to read, but the total for 2024 we recaptured was 260,000, a little over 260,000. And in the first quarter of 2021, we captured about 95,000, and of 2024, we captured 94,000. And then in the first quarter of 2025, we've already recaptured about 180,000.
Is that all due to the clinic operations and insurance?
Yeah. So if you look at the clinic revenue bucket here, the first quarter of last year, we only took in a little over 15,000, and this year we've taken in over 75,000. However, we do have an increased cost in the purchase of the vaccines. So when we were with our third-party biller, they purchased all the vaccines. We only received a small percentage back of that. Now we're receiving the billable rates back. So you see the clinic revenue, obviously is trending higher because of that. And then also our environmental revenue is trending higher because normally we receive a lot of the payments for food restaurant inspections in December, but there was a delay this year in some of the payments and it actually hit in January. So we're trending a little bit higher. We may see as as the year goes on for 2025, we may have more revenue in that bucket.
But we shouldn't plan for that.
Yeah, but we
going
shouldn't,
forward.
right, it's not, that's not a consistent.
Focus on strategy.
That's an offset. It was an offset. It wasn't due to increased permitting. It was due to delayed permitting.
Are there, unique procurement strategies for vaccines that would allow us to, like, I mean, source these?
We are part of a physicians buying group,
Okay.
that does allow us some discounts, which is a deeper discount than like a state, local government buying group.
Okay.
Although I am seeing with some insurance plans, they still are reimbursing us at a much lower rate than our cost is. So we're still trying to work through
Even in public health.
how to navigate that.
This is unbelievable.
Yes.
Sure, global on us.
So we're just investigating that more and through how to navigate that challenge.
What buying group are you part of? You know,
It is the Atlantic, physician buying group.
okay. I don't know if that's the same one that Suburban Health Organization is part of, because they have all of the donut hospitals.
It is, so we are grouped,
Okay.
we are grouped with a
With-
bunch of other practices, and that's kind of the model of physicians buying groups.
Yeah.
I don't know what other practices are in that group. They don't give you that information, when you sign up, so it's kind of like your buying power for the vaccines, I think, is across all these organizations that are part of that buying group.
Well, we would welcome any insight in you guys' experience. If there are other groups that might have,
Be more advanced.
yeah.
There are, we just have to see if you can get in, depending on what the restrictions are, is what I would say. Yeah. The other health departments, are they like, is
Oh,
that what the Marion County Health Department was in, or did they
Marion
get vaccines
County-
for children?
I actually don't know what Marion County is in. I know we polled a bunch of other different health departments to see. We're looking into 340B pricing, but that doesn't cover vaccines. So that's to reduce medication, and that's reduce cost medications. I can't remember what Marion County,
Oh, I think.
Well, they get a lot, they probably got most of it from
but
vaccines.
they
for
also
children.
don't bill insurance. Like,
Right.
so they would charge out of pocket. So their private purchase
Yeah.
stack is pretty limited because they, and in fact, I think they switched their model over to VaxCare so that they could take insured patients because they never took insurance except for Medicaid. Like when I worked there, it was Medicaid only. So if they're taking it now, I knew that they were piloting during COVID and then they paused it. And I think they re-implemented, switching to VaxCare, which is who we just switched off of. But they also, again, they never billed for insurance, for private insurance. They only ever billed for Medicaid.
Other health departments that I've spoken to, as far as I can tell, we're the only health department in the state of Indiana that actually is billing on our own without a third party doing that.
There's one other county that IU Health has got a relationship. So we have a relationship with Monroe County. I just don't know that we supply their vaccines and how that works.
Can I ask, do you have reps that come into the clinic? Yeah. Sometimes they can. I don't know anything about human medicine. They do come into clinics. So reps can do some things for their office with.
Yeah, we do participate in some additional stuff but those are usually for folks that qualify for discounted rates due to lack of insurance. For example, shingles isn't covered under the state program. But we're part of a program, I think it's GlaxoSmithKline, GSK, that allows us to be able to have a process for those where we're not paying for it. So we have been searching for all of those kinds of options, but as far as reduced costs, like we're open to any suggestions, connections, ideas, thoughts.
What is your payer mix? Like, is it?
The majority, the largest payer is Anthem, the second being Ambetter.
Medicaid, I mean, how many people walk in the door on Medicare, Medicaid?
When I last looked at it, we had about 60% insured population and 40%.
It's the biggest payer in the state of Indiana too, from a commercial standpoint, so it's,
We
that
are
would.
seeing more and more of the and better plan, which is a
Yeah.
marketplace plan with MHS. So we are seeing more and more of that. I think I have, the next slide is just more of a, just breakdown of the clinical revenue that I talked about, how, so in 2025, we've taken in a little over 75,000 in the first quarter compared to 15,000 in the first quarter of last year, but then you also see our expense is $63,000 in vaccines, whereas last year it's 0, so our net, profit is a little bit less this year compared to last year, but we're working on raising that bar.
Been a process.
Yeah. We've only been billing for 4 months. And then I think that's it. Any other questions on revenue thoughts?
I'm learning the reality that these people face every day, but so when you look at the bar charts there, when you look at revenue, is that revenue collected or revenue billed?
Collected, just collected.
And so what's the lag time on when you file with insurance where you actually get?
It's typically around 30 days with some
Okay.
a little bit longer, typically around 30.
And there are some weird hiccups, I think, when like a new insurance, was it the new insurance plan that came up that we've been struggling with? That it's a subset of, was it Anthem or was it UHC?
No, we're having some issues with our entanglement because we share a tax ID with fire. So it's happening with United Healthcare. Because some insurance companies will really just recognize you by tax ID, and some will recognize you by the MPI, the provider group number. And so working with our EHR system to try to work out those kinks. They're pulling in some of the claims and accepting as it works with Fisher's Health Department, while other claims are getting pulled in as the Fisher's Fire Department.
And are they denying what gets pulled in as the Fisher's Fire Department because they deny transportation, right? They
Well,
deny some of the EMS.
Yeah, it's different. It's not the
Different
same
services, yeah.
credentialing.
Yeah.
It's
It's different.
So trying to work through the issue with that plan.
If you can think of every logistical hurdle that someone would have to face, that's where we're at. Like with this entangled tax ID, these multiple funding streams, these having to have multiple buckets of vaccine with like every possible, let's make this more difficult to implement. That's where we're at. So we're working through it.
Most health departments don't.
Yeah, right. Maybe they were onto something.
Actually, you're in a unique position because of your payer mix to do it.
Yeah,
You're
And that was-
very fortunate.
that was why we thought we should, was because 90, whatever percent, Josh, are insured. 97% of Fisher's residents are insured, so we're like, okay, well, you're saying there's a chance, but it is complicated.
I'm gonna pass it to Jen.
Okay. So Jen Engelman, new Assistant Director of Health Operations. I come to you from inpatient operations. So this has been a big learning curve for me, but I'm on week 5 and doing a really deep dive, as we've heard why, into the clinic operations and really making sure that we're being efficient and meeting our community where the need is. And so I just want to highlight that that's really our primary responsibility, is meeting our community and the needs of our residents and the clients in there. So this is just a quick example of some of the deep dive that I'm doing, making sure that we're, that the hours that we currently serve our residents are, again, meeting their needs. We are analyzing, ensuring that we're maximizing the use of our clinic time, as well as our human and physical resources with the health department, and again, still meeting the needs of the community. We definitely anticipate our current structure as far as hours and days and times shifting as we expand services, which is what I will talk about next. And I know what you all are probably wanting to hear about. So yeah, next slide, please. Perfect. Thank you.
What's up with what day?
I was just like, there's a rush on clinics on Tuesdays or something.
So Tuesdays, Thursdays are evening times.
Oh, there you go.
Yes,
Excellent.
and Monday, Wednesday, Friday are 9 to 5.
It's everything. People want it to be.
Awesome, that's great.
Yes, but Friday.
Glad we do that, yes.
Friday's
busy.
Friday day shift, you can see, is very busy as well, so that was kind of interesting too, yeah. So no, we're not offering like a special lunch.
There's a problem. I have vaccines on Tuesday.
It's a great idea. Okay, okay.
We'll do that on Mondays and Wednesdays.
Yeah. So I know this group has been in the loop around all of our clinic expansion services, but I wanted to share our projected timeline. This is based on a number of factors, and this is obviously a very simplified version of that. Because the planning, design, education process is obviously very intensive. And so that's what we're almost completed with. A huge amount of work has been done by the team before I arrived, and I definitely would be remiss if I don't mention the public health nurses that have been really driving the programmatic changes here. So definitely want to give them a quick shout out. But without further ado, we will be rolling out our travel vaccines on March 1st. That's 1 week from today.
May 1st.
May 1st, yep. Before I started, we rolled out the travel vaccine on May 1st. And so that is huge because we will not be taking insurance for those. And that will all be self-pay, which is very much in line with what our competitors do and what other health departments do. This will be, we hope will be a very huge revenue stream for us because there's not a lot of competitors in the market as far as travel vaccines go.
That includes yellow fever?
Yeah. Yes.
And we've already received it. We have it in-house.
Yeah.
So for the public, this travel vaccine thing, is it something they can go online and say, I'm gonna go to this area, what vaccines do I need? And they just schedule an appointment?
So we are going to charge for a travel consultation fee, which will include a lot of that. So when they go to book their appointment online, the very first thing before they pick a time, they have to enter where they're going and when they're going. And so that will trigger the public health nurse to go into a program that we've purchased to say, these are the things that are recommended. So they'll come to the clinic appointment, they'll review again those dates and times where they're going, what they're planning on doing, because that also impacts what vaccines they'll be getting. They will review their current medication, previous medical history, et cetera, and then make the determination, these are the vaccines that you will need.
And the time frame that someone would need before their trip, or would you say 2 months out, 3 months?
Yeah, so I believe it cannot be more than 2 months for some of the vaccines, so we're targeting that like 4 to 6 week time frame.
Okay.
Is what we're gonna be advertising on the website. Obviously, dates pop up that they might have that. Yeah.
Perfect.
They'll also be receiving a lot of education around like food and water safety, insect precautions, et cetera. So it really will be like an all-inclusive travel consultation that we'll be providing.
And we also do like the prophylaxis, Jen, like other things that are not necessarily a shot.
Yes, so we'll be doing malaria for prophylaxis, not traveler's diarrhea.
Okay.
Yes. And so there's a long workflow for the health nurses to work through. Yeah. So again, we're very excited about this. We're not planning on publicizing right away because we want to work through the kinks and we anticipate there being a large demand for this. So once we kind of mitigate some of those barriers that pop up, then we'll work on publicizing.
And I should also mention, we've already had people like
Yes.
coming in for travel vaccines. Because once we got the yellow fever stamp, it went onto the CDC website. So we put a bunch of information on our website right now that says coming soon. We'll update that when we're actually offering them. But won't put it on social for a couple weeks yet.
So I was gonna ask that, so there's sources out there that would help direct people to go to the Fishers Public Health Department, they have these.
They're actually already doing that. So we're getting like.
It's actually a problem for us.
Yeah.
Right now.
Yeah.
It's very cool.
So it's open to, it's not just Fishers, it's anyone.
Correct.
Yeah. We happen to see that, they get funded.
And I anticipate there being a large
Yeah.
need from outside of Fishers for that as well, because like I said, there's really not a lot of places that are doing it.
Next year's one's like on 86th Street.
Yeah, Nora.
Yeah, and then there's one in West Lafayette, but
Yeah, but that's about
And then you have
it.
to go downtown.
Yeah.
Otherwise, you have to go to.
Yeah, you think of all the international travel just in Hamilton County, folks, either work recreational or otherwise.
Yeah, I mean, people go into Hajj, the Muslim community that we have here, that requires specifically like meningococcal, I think, for adults and a whole bunch of other stuff, so.
We have
Sorry?
the fee schedule.
Yeah, so there will be the $60 travel consultation fee, $20 per vaccine, and then the 110% of the cost of the vaccine charged to the patient. And again, that's in line with what our,
That's very reasonable.
So it's $20 plus the 110%.
Plus $60.
$60.
Plus the $60 consultation.
consultation. Yeah.
And some insurances may cover some of these, but our general practice is gonna be, this is pay out of pocket, you pay before you get the shot, right?
Yes.
And you can submit to your insurance company to see what, if anything, they'll cover, because every insurance company and every plan is different, and our system isn't gonna be good enough for us to be able to weed through that for each individual case. But they can do it, I mean, on their own, they can call ahead, and we'll have language that says, we encourage you to call your insurance company ahead of time to see what they cover.
It's a great opportunity to bring a lot of Fisher's residents closer to the health department too, that otherwise
Mhm.
maybe wouldn't have contact. So, great.
Any other travel vaccine questions before I move on?
I would just add that we have in the past had to do disease surveillance and investigation.
The pharmacist and people that know about vaccines on the board. A lot of the travel vaccines are also on the standard schedule. So, people are more than willing to get caught up on their standard schedule, or more than able to get caught up on their standard schedule before they come for a travel appointment. But it could be that we're recommending hepatitis A, and they may want to make a separate appointment, or they may want to just submit to their insurance company and see if they'll cover it. They may not if it's in conjunction with the travel appointment. The other thing is there are a lot of travel vaccines out there. The specialty ones, the ones that are beyond the ACIP schedule is that we're carrying right now is yellow fever and typhoid. But there are a lot of other ones like Japanese encephalitis, chikungunya, et cetera. We're not going to have those in stock right now. We still are covered under our standing orders. We built out the standing orders for all of those things, and we could add them on easily if we see a high demand or order on demand.
And that was my question regarding that, on the order on demand, what's the turnaround time on that?
We ordered Friday afternoon and they were here by Monday.
Okay, so it's not a significant
Real
delay.
quick turnaround.
So it's not like, yeah, your trip, yeah, you will have the vaccine will arrive when you're in there.
And if
We'll
it's something that
we'll
we're
ship it to
seeing,
you.
right, and once it's really hard too to predict some of this, because we've never done it before, right?
Yeah,
So
yeah.
there's no historical data to pull from. Once we start rolling, I think we'll see this is what the demand is, and we'll be able to pivot really, really quickly.
Do you have a requirement for the consultation so many months in advance of travel?
Not requirement, we're encouraging like 4 to 6 weeks in advance. Because I believe, I can't remember if it's yellow fever or typhoid, one of them you should not give more than 60 days in advance of the travel.
I think it would probably be typhoid because yellow fever is good for life.
Do you have to do series? One after the other?
Not for yellow fever and not for typhoid. Typhoid's only good for 2 years. So, you gotta keep doing that, but yellow fever should be good. Perpetuity, if you keep your vaccine record. Yeah, because it's actually required for a lot of countries to enter the country. Like you have to show it.
Sure.
So that's why we had to jump through so many hoops for yellow fever.
The only thing that I could foresee is if you're doing so many consultations, you might be running behind where trying to get people vaccinated in the time frame they need. Does that make sense?
Well, the consultation and the vaccines will be at the same visit.
Same time.
Same visit,
I think the only one.
unless there's something we have to order.
Yeah, that,
And we'll have that on the website too, because, everybody at home.
You actually have
everybody
minimum
knows
time.
that.
Yeah, there's a minimum, so you guys.
And I think that the minimum time, I think is like 10 days maybe I forget, I don't quote me on that on the recording, but it's, so the right is like, but if you start 6 weeks out, you can go as close to as maybe 2 weeks of
Right.
travel.
That's why they'll have to put their where and when, but when they're booking the appointment, so they
Okay.
can look at all that. Okay. Before they.
There's typically a fee for someone who wants to come back and get confirmation of a vaccination they've had.
You mean like their vaccine record? No. If somebody comes after, we have to do a release of information, like to them, to release their own records to them. They also have access to their patient portal, and there's also the state access that everyone has, MyVax Indiana, so we usually give those instructions out every time we
But that
vaccinate
includes
somebody.
these
like that.
travel vaccines beyond what you're.
It should automatically enter everything in there, but it's not gonna have their yellow fever stamp. That requires a very specific WHO record, but we can always refill that out. And, it could be an option for us to charge for that service going forward or not, but we don't charge for it now.
In the case of hepatitis, do you offer a titer as a service, or is it included, or?
We're not currently offering titers, although that's one of the kind of minor services I would say that we've talked about adding on. More for like people going into medical fields, because they require titers for stuff like MMR and, measles, stuff like that. So So we get a fair number of nursing students asking for that kind of service. So that's definitely something we've had on the list of like things to add after we get through these initial pieces.
It's very good. So we are also going to be rolling on sexually transmitted infections and pregnancy testing, and that will come 2 weeks after travel, so ish. So May 19th, I believe is that Monday, that we'll be going live with that. We don't anticipate that being a revenue generator by any stretch, but it's definitely something that we need to be doing to serve our community. So that will be, like I said, starting May 18th, 19th. And then I just wanted to highlight all of the things that we'll be continuing to evaluate after we go live with these services. To your point, time to next appointment, if we start, seeing that people are waiting 2 weeks to get in, that's a huge indicator that we need to expand our dates and times available. Which vaccines will be in demand, if we need to adjust which ones we have in stock. Obviously, our revenue and expenses, our client visits by day of week and time, we need to pivot and adjust as needed. And then our staffing metrics as far as how much overtime are we using, supplemental staff? Do we need to adjust our skill mix and adjust staff?
Yeah, just so I'm clear on the marketing piece for the STDs. This is the same kind of like soft opening, so to speak, like, hey,
Yes,
we're
yes.
just
Yes.
it's available, but we're not out there.
See how it goes, test demand, and then add it to our, have it on the website, but we're not gonna push it hard.
Gotcha.
And I also don't see a huge that taking off like gravel does, because there's so many other.
Well, not,
Yeah.
Right?
I think-
but if
Yeah.
it's there, and if they need it,
Definitely
it's there.
I think it'll more take off just,
Yeah.
like, Bellflower, for example, down in Indianapolis, they handle all of the reportable STIs, like the follow-up on those. So just them knowing that, like, we could treat, or that a partner could get screened up here will be, I think we'll see people just on that, because, there hasn't been any up in this area for a long time, as far as a public service for folks that we would have to drive down to.
So other than Bellflower today in central Indiana, there's no other public.
Public health, like Madison County, I think offers that you gotta drive north or you gotta drive south. And then the treatment and actually a clinical visit,
Yeah.
like when we start doing those, that'll be fairly unique.
Yeah.
But just to get people treated, I think Madison County does that. So I don't wanna exclude all of central Indiana. Hamilton County, I think, is doing like HIV tests once a month or something, but no treatment, no.
Yeah.
A full visit, so there are
Yeah.
other places doing things, but certainly nothing easy up here.
I was gonna ask about HIV test. That's something we plan on doing.
Yeah, that's part of it. HIV, syphilis, hepatitis C, gonorrhea, yeah.
And how are you doing the testing? I know the HIV serum.
So the HIV testing that we do, like we do HIV testing now, point of care for late TB, and then we would have a flex to and do it automatically. Our HIV case rates in Fishers are very low. So not expecting a ton, but we're prepared for whatever happens for the referral pathway.
Our annual incidence for HIV is less than 5.
And then the gonorrhea, chlamydia, how you doing that test?
So it's a send out. It's a
Swab.
self swab.
Self swab.
Yep.
But, I work in various places,
Yep.
and some places have the swab, and some places have a new swab where it has everything, like
Yeah.
the bacterial vaginosis.
And we've been looking at all of the, like, there are some really great, like, point of care tests out there too, like, that have results in 15 minutes. It involves equipment purchase that, we're pricing, we're looking at, so all of those options, I think, we'd love to explore. The funding constraints obviously limit what we can explore right away.
Yeah, I definitely would encourage because it's one swab and you get all this data.
Yeah.
So I'm gonna give an update on community health assessment, improvement planning, strategic planning, at all. So where we are in late 23 and 24, and was doing a very large secondary data analysis. I looked at over 100 different indicators that influence health and well-being, and they collected all the it together into a non-consumable 80-page report. Cause you know me, I do things concisely and quickly. But what that is to say is that, doing some of that intensive analysis also, it allows the level of confidence and precision indicators that we can see in progress as we build in. Continuous quality improvement, we define what metrics we want to target, how we want to evaluate, do course correction midway through, and test out to evidence-based or promising practices. So that large secondary analysis, I actually had an EPIC student with me for 3 months to help update, refresh, because these data sources refresh not often, but frequently enough that I was able to add in additional inputs. I then have designed an evidence-informed and validated survey questionnaire to get the voice of the residents out there for community health and well-being, to look across social determinants of health and well-being, and we're waiting on launching that very soon. Much of that will drive together the contextual aspects that we'll get out of focus groups to really get the understanding at lived experience level, and pull all that together for the health assessment, guiding our improvement planning over the next several quarters, and leading to our first fully published 3-5-year strategic plan. So definitely won't be able to go over everything that's in detail in this large secondary analysis, just some highlights by a few key topic areas to touch on. Maternal, and in many of these, Fishers performs extraordinarily across many health and well-being metrics. I was able to pull birth records and look at them individually over the last 15 years to do a deep analysis on maternal and infant health, but then combine that with death records to look at out and stuff like that. So on very key indicators, we do quite well. You know, high access to early prenatal care based on the recommended schedule by the 13th week, which is high breastfeeding at discharge, which is a good indicator of maintaining breastfeeding during the first year of life. High insurance coverage, we very low birth weights. Our infant mortality rate is less than a third of the state average. So most recently it was 1.9 per 1,000 live births relative to 6.5 for the state. And so we exceed in a lot of areas. You see differences across a number of indicators, whether you stratify that by race, age, payer status. So we can look at that. And so Black African-American mothers and Fishers, you know, they're 2.3 times more often delivering at lower birth weights relative to white mothers. Access to early prenatal care varies based on some of those factors. You tend to see very high uptake. Like I said, it's roughly 90% for overall population. But then when you look down, Medicaid is 66%, self-pay is a bit lower. There's some differences whether you stratify it by advanced maternal age or younger, and then also race, ethnicity. This information, when we combine it with both the survey and groups, really help drive forward strategies. We know there's a good enough signal. Pregnancy testing is the first opportunity to have that touch point to start to improve and figure out ways for maternal care navigation, but also enough of a signal to start this collaboration to co-locate how do we complement referrals and support at higher touch points within the community. And just based on the level of data access that we have in the surveillance capabilities that we can do, we can improve those to do more predictive outreach and more targeted outreach, because it's not just seeing this across community. I have the capability to see it as granular as census tract level, or even sometimes much more granular than that. Some chronic disease highlights, like I've mentioned, it's a very generally healthy population. We have similar or lower prevalence rates for certain chronic conditions. Our cholesterol rate is similar to the US, similar to county. High blood pressure, the same. Arthritis, depression, asthma, and stuff like this. You can see them listed on the table. And you can look at this over static time points. It's cross-sectional data to have access to this, but I can map this out across the community to look at differences across our geographic footprint. And then we were able to work with a local health system partner, and I was able to analyze 160,000 encounters and then weight those based on certain characteristics to look at utilization rates and tell where for certain chronic conditions we see repeated high encounters and high utilization rates, or signals where we see lower utilization rates. And there's interpretations that have implications for our programming that are different. So for mental health conditions, we tend to see much lower utilization rates, which is common, and we know, but we also know that Combining that with other information sources, we will look at its stronger signals of underdiagnosis, undertreatment, and lower mental health literacy that can improve our program. So we're getting our social care worker and health educators trained in adult mental health first aid back to improve mental health literacy. But finding this information allows us to be a lot more strategic in where we put our efforts. We can look at injury data. So everybody know this falls is the leading cause of preventable injury and morbidity. In Fishers, over the last 8 years, we've seen this increase in acute care need through ER presentations by a factor of 2. But we're also seeing other signals of increase or plateauing. So pregnancy-related ER visits uniquely is tripled for ER presentations. This include things to accidental injury, unplanned or emergency delivery, but also it can be signals for the maternal health journey during pregnancy. And we can get down all the way to the discharge diagnosis to look at better surveillance to start to understand what are some common causes and reasons for women who are pregnant presenting to the ER all the way up to loss. Self-harm and suicide-related visits, like every jurisdiction across the nation has seen this rise over the last 8 years. In Fishers, it's relatively a low number, but that relatively low number has increased by a factor of 2 over the last 8 years. We are seeing overdose visits to the ER decreasing in the most recent year, which I think is diving a little bit deeper on mental health. When you start to categorize all the presentation reasons, you can see that in generalized mental health reasons, which will capture behavioral health issues, those are increasing year over year here. Elsewhere, the suicide-related visits I talked about are increasing, but we can break this down and look at the burden of those health issues by age group, race, stuff like that. Our youth, I've compared this before, our youth fare much better than the surrounding county, which I think is a good signal of both the level of investment from the city and the school community on protective factors to help youth during their health journey. But we know other things. Depression is affecting just over 20% of adults in Fishers, but we're seeing this lower utilization rate, which means it might be a better opportunity to enhance the access to care system and mental health literacy to engage. Death by suicide, the event number is low. Thankfully, we have a very high, we live long. There we go. So we tend to see, and I'll show a quick slide on our leading causes of death. It's the common chronic conditions around heart disease and cancer, right? But just given the low event size, we do see suicide float in and out in our top 10 leading causes of death year to year. And so I just mentioned this, heart disease, cancer are roughly 40% in the estimate of their common conditions, stroke, kidney disease, chronic lower respiratory disease, consuming another 15% of the deaths. Alzheimer's disease as a cause of death is increasing. Unintentional injuries and death by suicide, relatively low percentages causes of death, but when you break it down in trends everywhere nationally, is that unintentional injuries are roughly 50%, so accidents, and death by suicide 30% for leading causes under 40 event sizes. We can look at where years of potential life lost are done in this. I've done this before, so just over a 15-year period, 6,500 years of potential life lost for residents due to cancer. It goes down to 4.6 for unintentional heart disease. See this down through there. So looking at health behavior, reported health status, most of these are either similar or lower than the surrounding county and the US in general. Low smoking rates, binge drinking rates, all of these are for adults only. 17%, 17% of physical inactivity rates among adults, about a third of adults that are getting less than the recommended amount of sleep. 11% of adults rating fair or poor health in the past 30 days, 14% with frequent mental distress. These are lower than US or county. And 9% frequent physical distress. You can look at health-related social needs, which we do report, is just under a third feel socially isolated. It's lower than the US. 1 in 5 lacking social and emotional support, which again is low in the US. Low rates of food insecurity and housing insecurity relative to the US or the county. And then low transportation barriers. And we have very low poverty rates. It often floats below 3% across the community. Only 3.5% of Fishers received food stamps, for example. Other elements that not in here today is going through the community profile, the demographics that change over time, the migration patterns, so that you can understand influx and outflux, longevity of stuff that informs influences on health. And so one last section is very high levels of income, median income, right? And traditionally very low levels of poverty. And I throw some up here. You see females slightly higher than males here. Obviously, there's that educational attainment relationship to poverty, or you can look at it by household structure and say the females with no spouse present but have children in the household experience slightly higher levels of poverty. You can break these down quite a high number of ways, and we do in the report. But when you expand beyond the federal poverty level definition and look at other measures that can influence someone's opportunity to sometimes maybe struggle with basic needs or not, there's the ALICE measure, which stands for Assets Limited Income Constrained and Employed. We only have 2 exclusive zip codes in Fishers. One of the zip codes, you can look at a ALICE household. Sometimes they may experience living paycheck by paycheck. Sometimes they may experience insecurity or hardship. They may be one financial emergency away from floating in or out or moving above. And so depending on where you look, it could be 28% households, 18% households, and this will change year to year. And it's obviously has much broader influences pushing out on it. So that's a very quick overview of very select things. Huh?
Zip code in Fishers.
It's not exclusive to Fishers.
Oh, that's why. You
Well,
can't figure it out.
we have, like,
I live in a different zip code. than
5
you.
zip codes.
Yeah.
But
Oh, yeah, because we have
So, yeah.
Noblesville, that zip code still has.
yes,
But you're taking the 2 that are
just
the
as
big ones.
exclusive, which when I first started here was just over 90% of our population. And it's roughly around 88% of our total.
That's a lot, so most people are like dumbfounded after they hear all that.
Well, yeah, exactly. Quick question regarding HIV pregnancy testing line. So we have a referral system in place for those people?
Yes, yeah. We're still working out all of the specific details, I would say, but yes, it will definitely be a warm handoff, if there is a positive.
Okay. Very good.
Yeah, I know last year we talked a lot about that we were going to do these things, and I think we were preparing for all of these things that can feel very impatient, like for me, for the mayor, I think. People waiting for the services, but we have been collecting, and there are so many pieces to this puzzle to put into place that we've been, trying to make sure they're all tight, and now we're in the roll them out, but we've got all the partnerships in place, we've got we've got the connection, we've got the
That's awesome.
yeah.
I guess we're on to contacts and grants.
This is the last slide. I do have one good news on the grant front. The FDA program standards grant, we did receive, official word last month that we did receive that grant. So that, funds our inspectors as they work towards standardization of all of the 9 standards through the FDA retail program. And then it also allows them, it provides funds for them to go to some training. That's very beneficial. We were not awarded USDA farm to school grants. That program has since been dissolved. So we're not awarded that.
No, they didn't even read any of the application,
Okay.
and they said.
Take that as a-
Take that as a.
Right.
That's sad.
It's not a loss though.
That loss.
Not a loss.
But, and we still do have our co-ed school liaison grant funds, available. So we have funded, some school nurse association memberships at HSC schools in St. Louis and Mumford. And then, we're also, sending a couple of our staff to a school nursing conference
And some of the HSC
and
nurses.
HSC
Yeah.
nurses. So we're supporting them in that way. We also this winter did an open gym program that gym was open on Sundays at Fisher Junior High, I think in the afternoons. We found that very successful. Families loved coming in, letting their children run around, kind of unstructured. So we supported that program. And then we've also awarded Shepherd Center of Hamilton County through HFI program funds to support fall prevention and their like reaching resource program that is for our senior. And then we also still have funds available in our school club grants. So we are looking for next school year to already push that out. In fact, we've already received an application for next school year that we awarded for a pickleball, HSC pickleball club.
Always a people.
And then as far as grants and development, that's just on hold right now. Questions on grants?
So we don't have any grants to apply to. We
Yeah.
don't have any grants to announce.
Monica mentioned the $1 million in direct savings from pensions. Is it really neat? With the fact it's $1 we spent, we're providing 30 to 30.
I was also reading there's 2 triathlons.
Yeah, so Jenny, who's our corporate health ambassador, I think is helping to, she's not running those triathlons, but when outside partners reach out and say, hey, we'd like to, host something like this. She's helping them work through the process to get, the city permits and, kind of understand the ins and outs of what needs to happen. But I think at least one of them is planning to doing this. So just trying to figure out how we can leverage her to help promote health, and she was kind of the project manager for the open gym program too. And she's already put together like a data package on the success of that. It's great, like lots of return visitors, lots of positivity.
I have a question for the folks in the, I guess, private / nonprofit sector of healthcare. With all the other legislation that's been out there, and is there any ramifications on hospitals or clinic providers that would push? You could see being pushed our way. I mean, is that an outcome that we're going to see? Because we also want to anticipate anything that's happening in the world of healthcare today that might lead into the world of public health. Do you see any ramifications from any of the variety of moving pieces?
That's why I was asking about the HIV, because I get in the emergency department, sometimes people will come and ask for an HIV test. Like in the emergency department, getting an HIV test, one, I'm not your follow-up provider. And the test results sort of ends up in a bin that someone else might follow up with. Someone usually does.
Yeah.
But I live in the ER world where things go wrong. And so nice having that kind of out where we say you should go to the Department of Health to get that done.
Well, if HIV tests are done, no, they are reportable conditions, so they
The
do,
lab
like
has
the
to report.
labs, technically, under state law. Physicians, hospitals, and labs are required to report. The most efficient and most effective stream for that is the labs have automated, like, they have a built-in integration with the state reporting system, so those, anywhere in central Indiana would go.
I guess I was thinking more in the ilk of like trimming back.
Yeah.
Medicaid rules.
Yeah.
So does that?
So that's
sort
the
of-
biggest, I'll be honest, that's the biggest concern, one of the biggest concerns we have. So there's a lot on the possibility of taking away the not-for-profit status. I think that's calmed down because I think that people realize that has other implications, especially in the state in terms of what we deem community benefit, what the state was gonna do. But I'll be honest, every day we're worried about that. If Medicaid does not survive in its current form, it will create an influx into all of our EDs because they will lose primary care. And then it will potentially create a lot of need for vaccines and other services, that being the biggest one for children. We have to remember Medicaid provides care for children, also for adults who are, meet the stipulations. That's a very real concern for us. Every
Because
day.
I see it all the time, like
Yeah.
more and more people are showing
Yeah.
up to the emergency department, not having a primary care provider.
It seems like the ER waiting rooms aren't necessarily filled with injured people. It seems like there's an awful lot of sick people that are just looking for their primary, like,
Yeah.
they're just looking for someone to treat whatever they have going on at the
Yeah,
moment.
it's a.
And I worry that with these moves, it's gonna push them into places that are already at capacity. And what is the bleed over effect at a time when we're also resource constrained? And what do we need to be thinking about and be prepared for? Hopefully we don't get to that point, but then maybe, travel vaccines may become a luxury if people are clearly looking for, I think I have a flu. I can't get in the ER because it's kind of where I'm supposed to go.
Right, and that's exactly.
And the other problem is they forego preventive care. So you think about
Right.
kids with asthma, and you think about other things like that. If you don't have access, if you don't have Medicaid, then you don't have access to primary care. And then you end up in the ER in extremis, and that could actually have been prevented. And so it does make us concerned about health outcomes too, and the need then for higher levels of care because you don't have good disease control.
Yeah. Or have the capability to look at 65 defined conditions for ER presentation for active surveillance. Flu and flu-like symptoms, and then an expansion of that, I do a lot of that. But there are some signals that we can.
Yeah, that would be good to think about.
It seems like we have a convergence of things occurring at one time, so. we can Navigate accordingly.
It seemed like that.
Yeah.
Just like that.
Perception is reality.
It actually is.
But I'm excited about the team, Monica's assembled here, I think. If anyone's gonna chart the course, we will,
Yeah.
especially with our president.
Long live Sal.
We did table.
We tabled the election of the vice chair. I saw the next meeting. Vice chair. So, I saw the next meeting July 31st.
Now,
I know, but I'm gonna be away in a vacation then. So we do need a vice chair, or we can move the meeting.
I honestly think, Monica, in anticipation of the budget for 26.
we need to move the meeting anyway, because I'm planning to be out of the country as. Oh, no, that's not it.
No,
Never
I
mind.
think we need to move up a meeting a little bit earlier, like in mid-June, because going into the budget. If we have to make adjustments or we have to think about priorities or programmatic elements, it would be good to have this board kind of say, here's where our priorities are. So that when we go into the council budget process, which really starts in earnest in July and August, we will have already kind of vetted all of that. So if we could figure out maybe have a meeting earlier, I think it'd be better.
Okay, well, we can do a poll or something. We'll shoot for Thursday at 11, and we should have.
Calendar, right?
I mean,
Wow.
we should, but I just and that's the trip out of is then. But we'll have other Thursdays at 11.
The HFI budget has to be turned in on June 1st.
Oh, that's a good point.
Well, that'll be pretty easy.
It'll be pretty
It's a much smaller number to figure out.
But it would be helpful to have it before then if that was.
Late May even.
Yeah, and we do have one on the calendar in late May.
Maybe that's-
It's just on there now, but yeah.
We have a meeting late night.
Yeah. Okay, we have them on the calendar every month. We
Yeah,
just.
Yeah, we were just,
cancel them every month.
That sets a good target for us to really get some clarity around these financial matters. Back good.
And I asked the other board people to think about your vice chair. We can table that vote. Think about what you want to do. In the meantime,
Does anybody want to volunteer?
Yeah, how about-
Entertained.
I mean, think about it. If you want to volunteer now, if not, then if you want to think about it for the May 20th meeting, think about
I
that.
do not want to volunteer. And I do not want to be nominated.
That's a, no.
Here, you But the mayor stepped in for you and said, well.
You're the best, buddy.
All right, so I would say just table that vote for the next meeting.
All right.
Just think about it.
Working on your campaigns.
Raise money.
May 29th is the one that's on the calendar.
Yes, yeah.
And then, is that it? Yeah. So what do? We, now, a motion to adjourn this meeting,
So move.
and then second, and then the votes, aye, and against, no, all right, meeting adjourned, thank you very much.